Great. Good afternoon, network, and welcome to the year's first session. I'd like to welcome you all and a happy new year to everyone. So today we're going to have an update on the 2025 Zambia National HIV Program priorities. On behalf of Prof. Lloyd Mulenga, we're going to have Dr. Sibile present this. Thank you for joining us, Dr. Sibile, for this session. So just a few house rules before we start. Let's all ensure that our microphones are on mute during the presentation. And then if you've got any questions, let's raise our hands and we'll attend to that, or you can post your questions in the chat box. And we'll be able to attend to that. Let's make sure the session is an interactive one. You may switch on your video so we can see who's attending with us. And then another exciting thing is that today we're joined by our panel of experts, of whom everybody's in this room today. We have Dr. Priscilla Mulenga, we have Ms. Mumbi Musosha, we have Ms. Melody Mbewe, and Dr. Chimika Piri. I'd like to welcome all of you to today's echo session. So at this point of time, I'm going to hand over to our presenter, Dr. Sibile. Dr. Sibile, once again, thank you so much for joining.
Thank you, Dr. Naik. I hope you can hear me. Just a feedback from our network. Can you hear me? Just somebody to confirm. Can you hear me clearly?
Yes, we can hear you.
Oh, thank you very much.
Loud and clear.
Happy New Year to everybody. We wish you God's blessings in this brand new year. Yes, so I'll present this on behalf of Professor Mulenga. So we are assuming that we are speaking to implementers of the HIV program, people we work with, as we implement and provide HIV services in the country. So the take-home messages from this presentation should be the things that we should focus on as we do our work in the facilities. Those representing implementing partners or sub-national organs is what are the key things that we'd like to achieve, even as we, some of us are preparing for our work plans, and those who already have work plans, how can we modify our work plans to support the National HIV Program objectives? Yes, so these are that's the outline for the presentation. We'll look at how we performed in 2024. Obviously, we'll just give some highlights, not in depth. Some of the data, as you might be aware, for the 31st of December is not ready. We are just 3 weeks from that particular point. So the data is still being cleaned. So we'll present the data as at Q3. MOH, that's September. So we'll look at the key achievements, the key challenges that we had last year, some of the focus areas and the priorities for 2025 this year, and also some key considerations that we'll discuss. I don't know if we are starting with a pause. I think. Okay, we can start with the poll.
Yeah, so we'll just jump into our poll questions first. Let me just launch it. Okay, so our first poll question reads, which one is true about the current epidemic response in Zambia? So option A is the country has only achieved the second 95. Option B, all subpopulations have achieved the 95, 95, 95. Option C, overall, the country has achieved the UNAIDS 95-95 targets as it stands at 98, 98, and 97. And option D being the number of annual new HIV infections is equal to the total annual HIV deaths. So let's all ensure we participate. I'll repeat the question. Which one is true about the current epidemic response in Zambia? Option A, the country has only achieved the second 95. Option B, all subpopulations have achieved the 95, 95, 95. Option C, overall, the country has achieved the UNAIDS 95, 95, 95 targets as it stands at 98, 98, and 97. And option D, the number of annual new HIV infections is equal to the number, the total annual HIV deaths. So we just have slightly under 50% that have participated. Let's ensure we all participate. Okay. I'll be ending the poll over here now and sharing with you the results, Dr. Sibila. We have majority, which is 57% that have opted for option C, being the country has achieved the UNAIDS 95-95 target as it stands at 98, 98, and 97, and then 26% for option A, and then 15 and 3% for B and D. Yep, you're
Lovely. Yeah, so I'm sure as we move on with the present discussion today, we'll have the answer to that question.
okay, great.
Yeah. We can back to the slide set. Yeah, so as you all know, our goal as the Ministry of Health as stipulated in the National Health Strategic Plan 2022 to 2026 with regards to HIV is to reduce the incidence of HIV from 28,000, which was in 2021, based on the Zambia 2021, to 15,000 by 2026. That's by the end of next year. So we hope that we are on track. So this is where we stand. As of September 2024, we had over 1.3 million people knowing their HIV status, representing 98%, and over close to 1.3 million people, that is 1.295, that's as of September. I must say by the end of December, the data shows that we've crossed the 1.3 million people on treatment. So that was 98% of those who know their status, and close to 1.2 million and 25,000 people at their viral load, which was suppressed below 1,000. And this is based on their team. So that was 97%. So we are at 98, 98, and 97. And as you know, based on UNAIDS data for 2023 December, we were at 96, 98, and 97. So for pediatrics, we have made some improvement. You remember that the first 95, we were at 72. We think we did well last year. We were at 782. So we went up by 10 points. And of those, 88% were linked to treatment. This is a bit lower. This number used to be in the 90s, so we need to do more with making sure that the children are on treatment, but viral load suppression is at 95, and we think this is partially due to the pediatric DTG and the combined, the so-called pod that's ABC and DTG combined tablet for children. So we are doing fine with regards to viral load suppression. For adolescents, we are almost there as well. And I must say, even for men, the data seems to be promising in some months. So for the adolescents, 95, 92, and 95. But this was just for one quarter. So we'd like to see a trend which is consistent. Yeah. So this is preliminary data. I must say this is from how the epidemic curve seems to look like. This is based on the preliminary spectrum estimates for 2025, representing the 2024 data. We seem to be there, crossing the lines are crossing. As you know, we define epidemic curve for those two lines. New infections versus deaths to cross, where the new infections are below the deaths and the two must be reduced. So preliminary data and the revised data seems to be looking a bit different depending on the assumptions and so on. Yeah, but we are very, very close to epidemic control, but we need to see these from different data sets. So with regards to key populations, you can see that the number of key populations of treatment has been growing. From 2022 to 2024, we've almost more than tripled the number from 8,000 to 25,000. But we still have debates on the overall populations of key population. For instance, just FSWs, there's some estimates which goes as high as 180,000. So if we have 25,000 on treatment and we have over 180,000, then we still have a huge gap of case identification for the population.
Yeah,
With that,
this is
thank you. Yeah, with regards to putting key populations on treatment, we are linking over 100%, and we know that viral load suppression is at 97%. So, and retention is okay. And also viral load coverage. Overall population is at 87%. For key populations, not so different, around 83%. So you can see that the main challenge that we have key populations is actually our case identification. That 24,000 is way below the estimates. 25,000 is way below the estimates. I would like another poll. You can launch the second poll.
Yeah. Thank you, Dr. Civilis. So I'm going to launch the second poll question. Okay, so just trying to launch the poll questions. Check it through.
Okay, if we can't, we can proceed for the sake of time. So this gives us roughly our performance in terms of where the coverage gaps are. You can see that where the red, we are not doing well. So for females, you can see those below 10 years old, and you can almost the whole country except Wapula. For young adolescents, 10 to 14, almost the whole country except southern, western. We do have sub-performance in Lusaka for adolescents and young people. That's 15 to 24 females. And we do have challenge again for those above 50, the females. We do have some coverage gaps. For men, we are not doing too well, even in adolescents and young men. You can see throughout the almost in all the provinces, and also men between 25, 34, you can see that there's just a few provinces that are doing well. So this is where the gaps, we need to look at men, mostly 25 to 34, adolescents, which goes up to 24 years old, and also children, pediatrics. These are the populations we need to focus on. We do have that signal for those above 50 years old. You know, now we need to be thinking about HIV and aging. Next slide. So we'll go into case finding to see how our performance has been. So this data is as of June last year. You can see that still the number of tests that we do has continued to rise. From the program side, would still love these tests to continue rising. We need to be prepared to do more and more and more tests, especially among those populations that we are not doing too well. Now we need to be thinking of more testing strategies of reaching those above 50 years old. How do we reach them? Yeah. We are seeing a fall in the positivity rate. This is expected. Yeah. Especially as we are going towards epidemic control. And still, we are finding almost 120,000 new, not really new. We know that most of these are actually recycled because they are coming as new patients when they are actually known to care. But in terms of positive individuals that we are finding, it's 120,000. There is now a concept of retesting for re-engagement. WHO has released guidelines for re-engagement, and we should not feel bad that we are using testing people who are already known to care to find them and re-engage them into care. It's a very important strategy. So the direction is still to look at ways of how we can do more and more testing. Next slide. So this is for adolescents and young people. We can see that we've improved in finding this population. It is a target population. And this is also to look at retesting for HIV negative pregnant and breastfeeding women. We continue to improve testing this population. Yes, last year we had a lot of talk about stock status for commodities. You can see that just to pick some of the months, this is how our performance has been in terms of availability. We do accept that there were some challenges, but looks like most of us did have some the testing stock that we needed, including oral quick at facility level. I'll move to treatment. So obviously the big issue in treatment is retention in care. You can see that interruption in treatment has been fluctuating. Early last year, we were around 2-3%, less than 4% average in the country. We can see that there are provinces that are not doing well. Northwestern province, 11%, the whole population. This is a big issue, and we think we'll continue to struggle with this, but we all know the target. The target is below 5% of returning individuals into care. The systems that we've put at facility level of quickly, when somebody has missed, they need phone calls and so on. We need not relent to do those things. Those are the best practices that have made gains. Appointments. We need to ensure that they continue doing those and following the SOPs. There is preliminary concerns about data in some of the facilities where we are not cleaning the data. So we advise that if your cohort is going down, and that's a true situation, let it record it as such, as opposed to you go in the system and you click somebody as active when that person is not active. You check in other records, triangulate, you find that that person is not in the DAR and so on. So you have this system where your TX car keeps on losing people every other month, because you won't be consistent to update those records. So let's clean the data. I think that's the lesson here. So with regards to age, we can see that those above 35, as expected, are doing better than the other population. It's also good to see pediatrics, being at least 10%, but even for peds, the target is 95% in terms of retention in care. So we still feel that we need to go through the path of unique IDs. We have the national registry. This will be supported by the scale-up of Smart Care Pro. We've had challenges. You know that. There is another challenge that has come right now for electricity. So facilities are saying, records are not being updated because half the time there's no power at the facility. We thank God for the rains, and I'm sure where you are, it's raining. We hope that the system the situation will improve. But you will see some efforts from HQ to solarize a lot of facilities. Right now, there's been a lot of resources from the Global Fund that has been channeled towards that. So to solarize the facility. So we do acknowledge that there's that challenge with our data. But we need to address the silent transfer issue with different modalities that we've put in place. So these are the emerging priorities and challenges. Obviously, the silent transfer issue. We have the minimum package that I'm going to talk more about. Integration, it's Smart Care Pro expansion, but we still need to have patient-centered care as we've been doing. We've seen a regression. I would say that we've seen a regression in DSD service, differentiated service model mix. So at facility levels, again, we question how many of us still have cards operating? How many of us still have community ART distribution working? So those are best practices that have made us achieve the gains that we have. We need to continue. Otherwise, we'll be regressing. Yeah, so again, we were saying we've seen that regression in our model mix for DSDs. Our core is to revive ourselves and begin to work harder, find ways. We know some of the models are costly, but these are the best practices, especially where we are going towards sustainability. Would like less visits at facility levels. It's one of the ways for having patient-centered care. Viral load suppression, we've done well, including coverage. You can see we are around 87. The target is 95. Yes, 95% of individuals on treatment should be should have a valid viral load test on the file. For pediatrics, you can see that slightly lower. I know there's complaints about phlebotomy, bleeding, and so on, but now we have a guide, the pediatric, viral load should be done on point of care tests. We know previously some of the point of care tests would not allow the DBS cards like the GBA, the GeneXpert. I think that will change as we spoke, because now we have different cartridges. You will be able to use the DBS for at the point of care test like GeneXpert for peds. Yeah. We've tried to track mortality as well. You can see that we are not doing too well. This could be an issue of records. Let's fill in our records well, but still around 7,000 deaths annually over a long period of time now. But I think this is a true representation of the picture that they are not reducing. If we go through your facilities, hospitals, AHD services are not okay. Yeah, there are a few. Last week, we were, I'll mention it in provinces like the North. We were in Kasama, the situation not too good. In our TWHD screening in the Copper Belt at 25%, at getting that screening, you know that we have, according to our HD guidelines, that those who have HD needs a reflex chest X-ray where possible, but we have places where, for instance, we're in Nakonde doing that, the whole Nakonde district has got that service is not available. Lab test, we agree that they were not there, and you've said that this is not because we couldn't procure them, but there's something with the manufacturer. Yeah, but things like crack, you find that our supply chain, when they've been available the whole year, our supply chain hasn't been that good. Yeah, so we need to do well. We have new tests for CD4 count, the Sysmex test. We know that there have been big facilities like Levy. Levy did have a CD4 count test. We hope that you get one of these Sysmex tests. Yeah, but we have the VCTech available, which you should be using. We need to order those. It was also nice that I find that some of the far-flung facilities like Kasama, they have VCTech. So that was quite reassuring. Yeah. But let's do well and reduce these mortalities. It's a key indicator, impact indicator for our program. If mortalities are not reducing, we can't say we have epidemic control. Yeah.
Let me share with you the link.
So this is just talk about baseline CD4 testing. You can see that again, yeah, this is our performance for last year. We can't say that we are actually doing well. Those that have CD4 count, you can see that we still have quite a good number coming in late, presenting late into treatment. Yeah. And here we've produced some guidelines of community AHD, which we hope that all of us will lay a hand on those, how we can make sure that even our CBVs can have some, some clues that this person needs quick treatment, referral, so that we prevent some of those things. Yeah, so these are some of the issues that we have. Yeah, I'll talk about. So for prevention, this is data from PEPFAR, but it's a comparison of 2023 to 2024, really. If you look at the MOH calendar, you can see that there is some minimal reduction in the new infections, but we know the targets. Yeah, that our target for the overall population is still, you saw from the curve, is 15,000. We are still above 20,000. So we can't say much. But we are going there. And these are where the hotspots are in terms of new infections. So we know the districts. You can see that the line of rail, including other districts like Mazabuka, Mongo, you are still in that deep pink. So we need to work harder in those districts. Copper Belt, pretty much the whole Copper Belt. We need to do a lot of prevention work. Kasama, Chipata, and my favorite district, Petauke, still a problem there. I spent my role posting there. So Petauke has always been a problem. Close to my heart, but not functioning, performing well. So other prevention services, we've been doing well. We know that we've done well in PrEP. VMMC, we can do better. GBV, we can do better as well in terms of our targets. So in other words, our program is so dependent on prevention. It's the key indicator according to our strategic plan. So we introduced Kabele, as you know, but for oral injection, oral PrEP, we surpassed the 1 million clients ever initiated. The pride of Dr. Piri here, seated next to me, he always says we are the program who've done that next to South Africa, which is a bigger program, just the 2 programs. So congratulations to everyone for your work that you have done in PrEP, but you know that we can do much better. Kabele, we've had over 2,000 initiates. We started in February, right? Last year. So we'll be celebrating a year soon. And you can see that the retention rate is much better compared to oral. So that's the direction we are moving. We've expanded the sites for Kabele. So get interested. That's the future. We'll be bringing in new products, lenacapavir, for Kabele, for long-acting injectable, which is a 6-monthly subcutaneous injection for prevention. So this is the future. For PrEP, we have target populations like adolescents. We need to improve. That 50% for HYW, we need to improve here. We don't have data for pregnant women as well, but preliminary data we have doesn't look too good for providing PrEP for pregnant women. So adolescent girls and young women and pregnant women are the two priorities that we have for PrEP. We know that, I'm sure you are all aware that even Kabele now, we've said you can give it for those who are pregnant. So let's target those two populations and see better results. So by and large, this is where we need to be focusing. Yeah, so the data from the ZDHS, preliminary data, Zambia Demographic Health Survey 2024 shows that, if anything, in terms of knowledge for HIV, comprehensive knowledge for HIV among adolescent girls and boys, it's actually reducing compared to the 18 in the ZDHS 2018, getting lower. It's like they know less than what they knew. Obviously, this is not a surprise because people grow, so less knowledge. Only 42%. Yeah, they know what HIV is, how it's transmitted. You can use very bad statistics. So all of us, whether you're in treatment now, whether you are doing biology, you work in the lab or whatever, we need to increase this indicator. It's a bad indicator. We've tried to do some sub-analysis to say maybe there is something. We pick single questions, but still the data is just bad. They just don't know. It's nothing like maybe the question was bad. It's just that the knowledge is not good. You know that we can't prevent. We can't have behavioral change. We can't have anything if knowledge is not there. It's a starting point before you have any form of health promotion, methods or whatever. Yeah, so it's a big call, wake-up call for all of us. We need to see more radio programs at district level on this, more posters, more TV programs, and so on. We need to flood our media with HIV methods. We've had some things we can celebrate about our, this was supposed to be our, not challenges, it was actually supposed to be our achievements, sorry. Yeah, so we did achieve for overall population the 95. We've crossed that 1.3 mark. There are some key documents that we'd like you to be aware of. The HIV prevention roadmap, which was launched by the minister in December. We ask that all of you get a hand on that document. It will tell us what we need to do as we are planning. How do we move on to achieve control of HIV by 2030? The sustainability plan, phase 1, a very good document as well that will tell us how do we now start reshifting our programming. We have the National Operation Plan for Elimination of Mother-to-Child Transmission of HIV. By now, with the kind of performance that we have in our program, we should achieve elimination of HIV, vertical transmission of HIV. So this is a key document. How do we reach there? So those are the documents that we ask that we lay our hands on and read them. We do have, okay, the owner of the program is correcting. It's supposed to be triple PMTCT, so she will give her a chance to tell us the correct title. I always get lost. Thank you, Dr. Mlenga, for being here. Yeah, so we do have, and obviously we are also happy for our cabinet work that we've done. We do have other documents. We have a curriculum for patient-centered care. You can get your hands on. We do have, I would say it's almost done, a package for mental health for primary health care service. We do have that document. We do have the minimum service package. Those documents are there, NCD, guidelines, and so on. Yeah, so we do have a lot of these documents for supporting the program. So these are some of the challenges. Obviously, that comprehensive knowledge is a big issue. High incidence as well. It's a challenge. It's something to look at. Silent transfers and the attrition rate that is not stabilizing. You see that it's some provinces, Northwestern, as high as 10. I know Dr. Molenga might not be happy with me. The DSD model mix, there's been some regression. Yeah, we are not seeing the cards. It's a fact. You agree with me? So she's a DSD coordinator. Yeah. Pardon? Yes. So we need to ramp up. So it's a key challenge. We were doing very well. Yeah. So we shouldn't backslide as it were. We still have breakthrough vertical transmission. So we should be aiming to reach that elimination. Case finding for children. Still a big gap. As you saw, that 82%, we are not happy. Smart care operational challenges. We need to do well with our electronic medical record or health record system. Yeah, so many challenges there. And there has been some logistical supply chain shortages here and there. Dr. Mlenga is here, you should say, including the benzene penicillin. That is not, yeah, but we do have several other test kits for various issues. So these are things that all of us, we need to work better. So going forward, our focus and priority areas for this year, 2025. So we need to be looking at how we can programmatic sustainability to maintain the gains. This is how we can now start moving into this sustainability mode, all of us. And there are key focus areas. One, we still need to close the gap through enhanced HIV prevention services. That combination HIV prevention, it's a top issue. We need to address the remaining gaps in those populations that are lingering on. We need to be thinking of redesigning our HIV services to achieve sustainability as we move on. And there will be, you'll receive more guidance on this particular third point as we move on. So the remaining gaps, we've mentioned them. Children, the first and second 95, AYP, all the three 95s pretty much. Gaps in men, pretty much 24 to 35. Especially the first 95. Prevention and case finding gaps for key populations. We know that we have that challenge to have proper prevention services for KPs, case findings. Our treatment card is at 25,000. Estimates of the number of KPs there in hundreds of thousands in the country. So redesigning HIV services to achieve sustainability, there are some things that we need to consider. The first one is decentralization of health services, health service coordination to make them local government centric. So we know that our district hospitals now, they've moved to local government and the DHD position has changed to a term that I always forget what are they. Okay, I'll not bother, otherwise I misquote it. Yeah, but I think the point is, yes, they're called Director Health Services. I hear if that is wrong, you blame Mumbi, who is seated next to me and whispering that title. Yeah, but what we are saying is we need to start having government-centric HIV services, and that's local government. All these prevention issues, they should go through that direction. We'll see more impact there. Other people have, doubts, but that's a directive. That's where we need to go, and we think there is light at the end of that tunnel. Integration of HIV services in primary health care. I was visiting a facility where they were trying to do the opposite, moving the ART clinic to somewhere else. ART clinic should be in OPD, at primary health care level. We don't want it to be like a specialized clinic. Have other specialized clinic. There are so many others. Eye clinic, dental, whatever, those are specialized. But ART is not a specialized clinic, should be in OPD, even geographically in your facility. That's where it should be located. Yeah, and it should be integrated with other MCH and so on, where those services are. That's where we want it to be. Integrating HIV services with other chronic disease. Obviously, we want ART services to also provide diabetes, hypertension, those and other key chronic diseases. Health system strengthening. We don't want siloed, logistics supply chain for HIV, its own track and so on. We need to be moving these things together. I've talked so much about DSDs, community-based and led services, but most importantly, we do have best practices in the HIV space, which should be routinized. They should become the order of the day. If we do that, we'll be redesigning our services towards sustainability. So we'll move into specific program areas. And I'll quickly, I don't know how much time we have.
15 minutes.
Okay, yeah, so I'll quickly maybe do this in 10 minutes so that we have some time to discuss. So, other prevention, HIV prevention. So, our key priority areas specifically is to address HIV diagnostics challenge for PrEP. As you know, you see a proper guidance here, but especially for Kabele, there were some individuals who tested negative on our algorithms, but they were actually positive when we did not. So it means we need to do better, especially with Kabele because of that Levi syndrome and so on. That needs to be addressed. So you see guidance. Watch out for that. Watch out for DVR as well. Lenacapavir and DPP. DPP is just a dual prevention where a pill which has got both PrEP and family planning. I still have to orient myself whether it's family planning or contraceptive, but I'll call it family planning. Yes, yeah. So we'll introduce this. So watch out for that. STIs are an issue. I'm sure if you attended the conference, we dedicated a session to this. It's a big issue. On Wednesday, we are revising our national strategic plan or operational plan for STIs. You see a lot of movements in STIs, both in prevention, case management, and also just treatment and testing for STIs. So coverage for key populations and vulnerable. So we need to be thinking of how can we routinize even key population services. There is some movement. Some of you should be aware that we want still some of the public health services to start providing some key population services. We've been doing it at UTH here for over 5 years. You are aware, you saw these things in the media. It is possible. HIV drug resistance testing, monitoring among individuals with incident PrEP. We need to strengthen this. It's now part of our guidelines. Everyone, whether oral or injectable PrEP who's positive, they need an HIV drug resistant test. We will need data, we need record, we need to know what's happening in that space. We've talked so much on supply chain. We need improvement. We need a bit of some more implementation science, and there's some modeling and so on how we can still do better targeted HIV prevention. If you read our plan, our roadmap, this is one of the core strategies to have, laser or streamlined of, targeted HIV prevention services, and this can only come from our implementation science to see what works and what is impactful. And obviously, we would like to scale up Cabaret, and when it comes, Adelena Cabaret. We have to do some behavioral risk reduction intervention, including harm reduction strategies. You see the MAT clinic, methadone clinics coming this year. The procurement for methadone is in place. We're arriving soon. That's the direction we are going. So obviously, we have to attend to these key populations. Data issue, I can't say much about that. We all know, that we have data challenges for key populations, but the system for data is there. The system for key population data is the NACMIS. The data at facility level or those program level of activities there, please help us to find that data. It's to make sure that that data finds itself in the NACMIS. The people in charge of the NACMIS are the DACAs at district level. We are asking for district health officers, district HIV TB focal point person, partners working in this space, please get in contact with the DACAs and help us to put the data there while we are trying to strengthen the operational issues, because the data systems are there. It's a NACMIS. And I'm sure some of you are asking, what is a NACMIS? So this is an electronic medical record system that is based at NAC to capture this data. So that system exists. For VMMC, you see, and we'll call some of you for an operational plan which needs to be redone. We need more surveillance on adverse events. We need to do better on commodities by forecasting and quantification. Sites will be visited for quality assurance, external quality assurance. We need mentorships. And also we need to develop a program manuscript for how we've performed for VMMC. HTS, we need to re-strengthen HTS and target the populations of interest, adolescents. We need more testing, universities and colleges. We'll need a workplace HIV testing strategies with champions put in place. This, especially for males, that's a way to get males. Index testing, social networks testing are still our key pillars. We need to continue and strengthen them. We need to see ways of how we can scale up the status neutral approach. We'll develop packages, SOPs, and guidance documents. That's the direction, meaning that somebody who, even if they are negative, they will still be in care. Even indicators, like an indicator for those who are on prevention, a prevention car, a TX car for prevention if you want, something like that. So they need to be followed permanent. When they drop off, you look for them to bring them back into that prevention cascade. Yeah. And obviously, we need more modalities for self-testing, including blood-based self-testing. Pediatrics, PMT and PMTCT. So we have data issues in PMTCT, and we are asking for help. Mainly, some of the challenges is there's very little smart care at the MCH. So there's that data gap. We are asking for partners as you do your mentorship, support, and so on. We want you to visit PMTC and sort out the data issues. It's having an impact on our spectrum estimates. Some of the errors and so on, we think it's been traced from the PMTCT data. So please, it's a focus area. You can see so many activities that we'd like to do for PMTCT data. And this is what has been planned. So when you see these activities at site level, don't be surprised. But the core, mainly, we need to enhance data use, and also we need to have data accuracy for PMTCT. We need to scale up that use of EMR in MCH. We need to have dashboards, cohort monitoring, mentorship. We need SOPs developed and enhanced. So these are our priorities. Continuing with PMTCT, we need to increase the second month EID coverage, including the 24 monthly final status coverage, right? Yeah, so that's what we need to focus on. There are some priorities for pregnancy and prenatal screening. We need to also go ahead, as you know, it's triple elimination to introduce the universal hepatitis B birth dose vaccination. SBC needs to be enhanced for PMTCT. Like I've said, this is a key population for our pregnant and breastfeeding women. We need to see that data starts going up. We need to do well in that space. We need to enhance retention. So we were looking at data for retention for pregnant and breastfeeding women. And we were surprised that we followed even some of the facilities that actually the dropouts are higher, even higher than the normal population. So more counseling, more information, even mental health issues for retention, for especially those diagnosed during pregnancy, issues like this pregnant woman was found positive, started on treatment, then the husband said no. It just shows that we have gaps in our system then, and the woman just disappears. Yeah. So those are some of the cases. So pediatrics, our main issue is case findings. Know your child status plus. We need to extend to the fathers living with HIV. We need to have SBC campaigns for PIDS case findings. We need to focus first on some of the health facilities that are not providing ART. So this is a guide. You see that pediatric ART services are universal. All facilities, ART facilities should provide that. If their facility is not doing that, reach out for that technical support that can be established Now the drugs are easier. There's no reason why we should be afraid. So this is what I meant. We need universal access for pediatric ART, all facilities. We have over 3,000 ART facilities. All these should be providing pediatric ART services. Yeah, we need to develop pediatric-based EAC tools. We do acknowledge that our EAC tool lacks somehow to attend to some of the pediatric needs. You see those tools developed. I know this has been a promise for a long time, but this is one of the priorities and focus for this year. And obviously, we've talked about point of care tests and other SOPs for transitioning from pediatric clinics to adolescent or adult clinics. We need to do better at this. So adolescents, case finding is still an issue. We need to have differentiated HIV testing for adolescents. We need to start from where we are supposed to be, raise that awareness for prevention methods, case finding, HIV, what it is. We've shared the sad news from the ZDHS, and we need more adolescent center of excellences to be established. For treatment and care, we need to continue reducing that silent transfer. We know that the baseline viral load SOP is not used in some places. Please note that that's a national guidance. Some people are afraid reclassifying individuals. We need to do that. We have developed the minimum service package. We need to operationalize it. It's being linked to SQA system, service quality assurance system. Advanced HIV disease package, we still have challenges. I've mentioned those. NCDs and mental health integration is a priority. HIV drug resistance, we are still not getting as many tests as we would like to have in terms of HIV DR, and we still have challenges with interpreting them. Pathways, now we are happy that results are reaching facilities. We are happy about that. We work on interpreting. Yes, we want to revise the tools.
Oh, that's an engagement. But no,
Yes, models will have to revamp, and we need to continue optimizing. Patients who need to be on Tafet, they should be on Tafet. Second line, we need to move individuals to darunavir, and when we do have the nekapravir for third line, that would be nice. So we need to consider, look at this year with the lens of sustainability, think of how we can scale up Smart Care Pro, support that. We await the ZDHS final results. Preliminary results not reassuring that we are, especially on our information, we are not doing too well. We have the new 3-test algorithm for HIV. We need to be moving towards that. We have some threats of emerging infectious disease. You know, we have mpox, cholera in some districts, Marburg virus in our neighboring countries. Outside our neighboring countries, you have the developing human metapneumovirus as well. These are other considerations. There's still this issue of weight gain and hypertension due to some ARVs, HIV and aging, because of, you can see the data, newer drugs like lenacapavir for treatment and prevention. We need to think of how we can redefine key population programming, status neutral as well. There is an issue of cervical cancer screening for PHIV. You see guidance that the guidelines, our guidelines may not be correct because things have changed. So really, I'll share with you this memo, reminding everybody that we are moving to the 3-test algorithm, and that's how it's supposed to be done, our HIV testing. This is just according to our NSP, you need to read the NSP. This is what you find concerning HIV program. These still remain our priorities because we want to do this till 2026. Yeah, so sharing with you these, including STIs. Yeah, so in conclusion, let's think of this year as focusing on reducing on incidence, sustainability of the gains and cost effectiveness of our programming. We need to start streamlining ourselves towards being government-centric. We need to close those remaining gaps. Thank you very much. I don't know if there's something that my colleagues here, Dr. Mlenga, running the PMTCT and DSD program, that they want to re-emphasize on, and Dr. Chimika, I would like them to say one or two things. Dr. Sivan, any addition? I think most of the things are covered that I have a potential. Thank you.
Good afternoon, everyone. Dr. Sivide has actually spoken well on the PMTCT program. So our program, we are focusing on triple: elimination of mother-to-child transmission of HIV, syphilis, and hepatitis B. Yeah, so let me emphasize that what we are eliminating is not HIV, it's not syphilis, and it's not hepatitis B. What we are eliminating is mother-to-child transmission of these specific 3 diseases. So what is different from what we have been doing is we've just added the hepatitis component, and the critical to do the interventions of hepatitis B is the introduction of the birth dose, which Dr. Sivide has ably explained. So we are following the universal birth dose. So that means every child born to a mother, whether tested or not, they would have an opportunity to be given the birth dose within 24 hours. So we are just like now putting things in place. The policy guidance, the operational plan is ready. We are just now trying to ensure that we kickstart the process of implementation. Thank you.
Right. Thank you so much, Dr. Mlenga, Dr. Sivile, for this lovely presentation. It's exciting to see where we're headed to in 2025. So at this point of time, I'm going to open up to our network for questions for our panel, our presenter today. And we'll start with Oscar Malakata. Kindly introduce yourself. You may unmute, introduce yourself, and you can go ahead with your question.
Yeah, thank you so much. My name is Oscar Malakata, I'm a medical doctor. Thank you so much, Dr. Sivile, for the nice presentation. and Dr. Priska Mulenga for the contribution. I have about 3 questions. Firstly, I'll need to start with case finding. I think one of the issues that you raised in terms is stop testing kits. Before we had the dual syphilis testing, we also had a challenge in terms of the syphilis testing as well as the benzathine penicillin for those that tested syphilis positive. One of the issues that has been raised from times immemorial is poor consumption data. Because at facility, district, and provincial level, the providers would have claimed that they provided consumption data, but there's disparity in terms of what is recorded at facility and what is at national level, which leads to the unnecessary stockouts. And as long as we don't have test kits, and especially when it comes to the PMTCT program, retesting of pregnant and breastfeeding women is a big challenge. And even when it comes to pediatric ART, we realized that according to the study which was done at UTH in East and Southern Africa, it was agreed that I'm having feedback. It was agreed that all pediatrics that are admitted should be tested. But if we're having these stockouts, case identification becomes a challenge, including identifying pediatrics that are supposed to be put on treatment. So what is the plan going forward to ensure that these gaps are mitigated? Then when it comes to IITs, I think we have a challenge because different provinces, different partners have different SOPs for the appointment system. What is supposed to help us is to have a proactive appointment instead of a reactive appointment system where we start tracking clients after they have missed an appointment. The expectation is we need to have a standardized appointment register, and all clients on the TX car should have future appointment dates documented in the appointment register, so that even the reminder system should be effective, so that even before they are supposed to come, they should be reminded. The day they miss an appointment, immediately they should be documented in the tracking register, and the tracking starts immediately. What is the way forward with respect to standardized SOPs and appointment registers so that we have a uniform national appointment system for breastfeeding women? We realize that retesting of pregnant and breastfeeding women is a challenge because, one, the community component is not strengthened. We have lay counselors and CBVs that are not competent enough to know the documentation and the tracking system. They have put some of the lay counselors on their payroll, others they are still depending on stipends. What's with respect to the community component? And then for the retesting, we don't have an appointment register in the MCH unit for the pregnant women as well as the breastfeeding women. For the breastfeeding women, it's even more complicated because the appointments are done during UCI at community level. Two, the registers are a challenge, and we need to see how best these issues should be standardized so that we can improve in order also to ensure that we improve in terms of prevention of mother-to-child transmission. Thank you.
Thank you, Dr. Malakata, for your questions. Dr. Sigile, Dr. Mulenga, would you like to take some of those?
I'll take about 2 questions. The first one is on the HIV syphilis dual testing. Dr. Malakata, when you introduced a new program, you find yourself having like some teething problems, we introduced the HIV syphilis dual testing in late 2021. But as at now, as we speak, I can assure you that we have stabilized. Starting from 2023, as far as I'm concerned, the implementation is going on well. I don't know, we should have people from provinces and districts to confirm if we have stockouts on testing. I'm emphasizing on the dual tests themselves. As far as I'm concerned, we have adequate stocks at SAMSA, and we have not reported any stockouts. If there are stockouts in the facilities, then it has to do with the issues of ordering, logistics management. Of course, benzathine, it's a different story, and we are trying to do what we can. We are trying to work very hard to ensure that we do have resources, adequate resources actually, to ensure that after testing, a woman is treated. So that's what I can comment on the HIV syphilis dual testing. As at now, our training facility-based, and we are doing this in a phased approach manner. So for phase 1, the idea is to train every facility. We have about 3,000 facilities where PMTCT services are being done. So for phase 1, we trained 837 facilities. We are currently in phase 2, and the target is to train 1,050. And by February, we should have done with phase 2, and phase 3 will all the facilities that will remain from the 2 phases. So in terms of progress, we are doing well in terms of testing using the dual testing. If there are issues with the test kit itself, this is the time at least to update or just inform us. We have changed from the time we introduced the dual HIV syphilis. The first test kit is different from what we are using now. I think we had presented, maybe including on this forum, we started with a different one, and we had reports of false positives. But what we have now, I'm yet to receive such complaints or such issues. What we are using now, I think we are moving in the right direction. That's on the HIV syphilis dual testing. If I may be allowed to proceed to maternal retesting, we know that we have not implemented well, and even just the data shows that our implementation of maternal retesting has not been well. So we are also working to address this gap. And one of the interventions that we have, one of the interventions we have planned to put in place is to ensure that we have an effective appointment system. I guess end there for now.
Thank you, Dr. Mulenga. Doctor, I'm sure Dr. Mulenga has answered most of your questions. So Jackson Mwewa, may you please unmute yourself, introduce, and you may go ahead.
Okay, thank you very much, Dr. Silvia. That was very profound presentation and enriching. However, I just wanted to find out on 2 things. Looking at the HIV-related mortality as it presented, which is still high, we saw this take to be a game changer in terms of decision-making for AHT surveillance. However, the stock has actually been depleted. I wanted to find out what's the stock status of this take at national level. Yes, then the other question is the Kabele, which has also come as a game changer in terms of HIV prevention. We saw it being rolled out in other provinces, and the facilities mentioned, if you like, Mazabuka and Nakonde. However, I wanted to find out, when are we rolling out to other provinces like Luapula? I submit, Chair.
Thank you, Dr. Muir.
Thank you, Dr. Jackson, for the presentation. So I must say that VisiTech has come here to stay. Initially, we had about 80,000 kits that came. The small challenge with VisiTech is that it has a short shelf life. And so, and as you know, it's the first time we are procuring that commodity. So that particular commodity had a short, it came here with a short shelf life because of the process. So, but right now we do have, and in our focus at quantification, VisiTech is the main source, is a main platform that we'll be using at the moment. Now, I have a request for all of you colleagues. So we do ask that VisiTech is used mainly for the TX news, those the new diagnosed. For the inpatients, there will be 13 facilities which will receive a Sysmex platform, and will only going towards the end of this year will probably remain with only those 2 platforms, including PMAs. So some facility, 3 platforms will have PMAs as well, but the fax presto, the amount of reagents that you have is the last stock. So we will not have new reagents for that. So what we are asking is different facilities who have different modalities of testing. We cannot afford to have all facilities to have Sysmex, all facilities to have PMAs, all facilities to have VisiTech. So it's a way of mapping. So there are some facilities which, especially smaller facilities, you only have VisiTechs and mostly for TX news. Mid or admitting facilities you have, and bigger facilities, Sysmex, of which most of the work will be those who are admitted and so on and so forth. Then we do have facilities which will have the PMAs. As you know, the PMAs have given us a lot of problems with them being able to work. They are down most of the time because of just the technologies. So it's that mapping that we want you to be aware of, So know your facility, what is the CD4 testing, provision that is dedicated to your facilities. And with that, please liaise with your chief biomedical officers in your provinces. They will tell you this facility, this is a platform you're supposed to be using. So we will not all be using the same platforms. Thank you. Dr. Piri on Kabele, when is it going to Wafula?
Thank you for that question. So first and foremost, I want to appreciate Wafula and Northern Province for their patience. Out of the 10 provinces, these are the only 2 provinces that we haven't started implementing the long-acting injectable Kabele CAB. So it's one of the priority activity in terms of scaling up, as you saw. So what I can promise is that in Q1 of 2025, so before the end of March, we should see some movements in Wapula as well as Northern Province. Just a few days ago, we were Northern Province, and I made this commitment as well. So we are working in the background to see to it that we introduce Kabele in your provinces as well. It may not be all the size, but to be some selected size. So we're excited to come to those 2 provinces, and then that will mean that we have covered all the 10 provinces at least. That's our picture.
Thank you, Dr. Piri and Dr. Sibile. So we've got a number of hands up, but just before that, we've got a comment and a question in the chat box from Daniel Kabamba. Thank you so much for that. So concern is about the monitoring of recipients of care, especially at the kidney function in the year 2024 was not good. So what measures have been put in place in regard with the reagents for chemistry? I think it's more of a procurement question.
Yeah, so again, what we are asking here is, you remember one of our approach is to see how can we redesign the way we do things. So we advise that not all facilities, again, will have a chemistry test. So we need to have that hub and spoke model being operationalized. Yes, at the end of last year, there was a big challenge, 2023, but for bigger hospitals, pretty much the last year, chemistries were a bit, there was more of some improved commodity security. The comment is, for facilities that don't have, find ways to have that courier systems to have those tests done where at the hubs. So we do have provinces like Southern Province, which has actually earmarked and classified which facility is a hub, which facility is a spoke. So let's identify hubs. Yeah, so we need to redesign. Let's know which facility is a hub, and that's a facility where we'll put most of these pressure equipment to make sure the supplies are there and so on. But for the others, it's a hub and spoke model. Thank you.
Thank you, Dr. Sibile. So, in view of time, we'll take the next two hands that are raised. We'll start with Dr. Mwape from Lusaka PHO. Kindly unmute and you may ask your question or comment.
Thank you, Facilitator. Good afternoon, Dr. Sibile and team, and thank you for the presentation. My question is on the VL coverage. You've mentioned, Doc, that our coverage has plateaued at 87%. And we know that the current denominator that we are using of TXCAR 6 months ago is not helping us. My question is, as Ministry, are we considering changing the denominator to eligible VL clients?
Thank you, Dr. Mwape. Agnes, would you like to unmute and ask your question or comment?
Yes, good afternoon.
Agnes, may you go ahead? Unfortunately, we're not able to hear you. Are you able to type your comment in the chat box? Okay, so we'll go ahead with the first question then from Dr. Mwape.
Yes. I'll pick that one. Thanks, Dr. Mwape, for bringing up that issue. Yeah, our promise, I think, is we will try. I know you've brought up that issue to me personally before, even how just SmartCare classifies someone who's eligible and so on. Yeah, we'll try and take that as one of the priorities. We'll take that as a submission that we should consider redoing how we do some of these calculations. Yeah, there's been quite some complaints from a lot of you how sometimes somebody who is classified as due because of that 3 months where the result is not yet back and they are dropped, that sort of thing. So we need a window. Yeah, so all those issues we have to sit down with this year with IHM and also PEPFAR. to see how we can agree on how we will redo the indicators. Thank you.
Thank you, Dr. Sevilla. So, okay, we'll take the last two questions. Dr. Malakata, you may unmute, and then we can go to Sydney from USA.
Yeah, thank you so much, Chair. I think my concern is on a decentralization of health services to Ministry of Local Government, which Dr. Seville ably articulated over. But we realized that we had such a system in the past, and the challenge that we have with Ministry of Local Government is funding. And as we are aware, even just payment of salaries for the council workers is a huge challenge. Sometimes they go 4 or 5 months without getting their salaries. And when it comes to primary health care and HIV services, Dr. Seville talked about having HIV services integrated into primary health care in OPD. But of course, training is required. That has been catered for. My concern is on funding. How are we assured that we are going to have consistent funding, just like we have had under Ministry of Health? Because even under Ministry of Health, we have got challenges for district receipt of the monthly operational grant. So how sure are we that local government is going to do better than the challenges that we're having under Ministry of Health? Thank you. I submit.
Thank you. We'll take the last question from Sydney. USA, may you please unmute and go ahead.
Thank you so much. This is Sydney Kawe, representing USHZ, Zambezi Hub. My question is on whether Ministry of Health is considering to implement the 12 MMD. Because if you look at the retention for Northwestern, which is at 89%, I think we have a lot of challenges. Like for instance, I give an example of Zambezi. Zambezi has two demographic areas, which is the West Bank, which is cut. Most of the times, these people are cut during the rain season. The areas are flooded. So if Ministry of Health can implement the 12 MMD, I think that would be a game changer for rural areas. So I don't know what is the update on the 12 MMD. I submit.
So much, Sydney from USAID. So we'll take those two questions and comments.
Yeah, so the question on security of funding for the district health officers under the decentralization system is a difficult one for me to answer, but I think the decentralization policy is the way forward. As you know, Doctor, that other countries have done it, like Kenya, it's working well, and there's a lot of positives to it. So it's for us. I think the leadership, national leadership gave that direction. It's for us technical people to see that it succeeds. So that's our baby, to make sure that it does succeed. And I'm sure funds come from the same coffers. They will be directed accordingly, but I cannot give that assurance. I think so, probably, yeah. For the question on 12 MMD, the answer is we don't have that policy, and when it came up, there are so many reasons why we shouldn't give that recommendation in the country. So you will not see that guidance coming. We know that there are some partners doing some pilots and so on, maybe at research level to see implementation. No one can stop research, but as policy, the answer is, for now, it's not the direction that we want to go, because there's the feeling or the understanding is that our procurement supply system cannot support that policy. However, and this is with a lot of caution, the service that we give is patient-centered. So if there is an individual who has reasons, who needs such a service and traveling out of the country and so on, you can consider giving, but you have to document why that particular individual has been given that particular service. So we are all clinicians and we know that we do things out of the guidelines in exceptional cases. Yeah, because I'm saying this because I've been to facilities where I've seen the treatment curve going down. They say, but these we know them, there's a mine which has been open in the bush, they go for 6 months, but they don't qualify for MMD because they are new patients. So we will not give them. I think that is wrong. When you have such a scenario, you can liaise with other people and, you know, put the rules aside for the good of the individual. Yeah, so like your situation in Zambezi, I usually get my map wrong, whether the valley side, I call the Zambezi Valley, it's part of the district. I know, I've been there, I know that it's a tough situation there. So things like that can be done. If there are some issues, logistical issues with other people, you can reach out to us, we can discuss with those people and support the care in the swamps there in some basic districts. Thanks.
Thank you so much, Dr. Sevilla, and thank you for your questions. So at this point of time, I know we've got a number of hands raised, but at this point of time, it's about 7 minutes past 4. I think we shall call it. We shall end the meeting, and I'd just like to thank the network for being so great and coming up with all these questions and comments. And lastly, I'd like to thank our presenter, Dr. Sevilla, our panel of experts. Today we have a full house of our panel. Thank you so much for being there. And till next time. So we'll see you in 2 weeks' time on our HIV and TB Echo. And wish you a good afternoon. Bye-bye. Thank you.
Thank you.
Thank you.
Thank you.
Signing off.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you. Have a blessed day.
Thank you. Thank you.